In this video, I want to explain to you all about what is in vitro maturation, or what we call for short, IVM. Now, it sounds a lot like IVF, and there's a reason for that. It is a lot like IVF. However, the developmental stage at which eggs are at when we begin to work with them is different. Like the name suggests, they're immature. So the first thing to understand is a little bit more about the developmental stages of an egg or an oocyte. Normally, when an egg is released from the ovary in its natural state, it's in what is called its mature stage. If you want to get technical, we sometimes refer to that as an M2 egg. Likewise, in IVF and treatments, we're requiring multiple eggs. It's the mature eggs that are targeted to be removed from the ovary because those are the ones that can be fertilized. For an egg to reach a mature state, it has to go through two steps. It has to first grow inside of its follicle unit, and that usually occurs over a period of about 10 to 12 days after exposure to hormones. The second step is it has to be exposed to a spike in one hormone called LH, and the LH then signals the egg to go through its final developmental stages. And we can actually see these at the microscopic level. So when we're talking about maturity versus immaturity, what we're really talking about is, has the egg that's been released gone through its development so that it has the ability to receive a sperm immediately upon ovulation or removal from the ovary? Remember, an egg has to make that transition to lose half its DNA to get ready for the sperm to come on in. It's a single cell, and it has to basically dump half its DNA contents just prior to it being able to be fertilized. Has that event happened at the very end of follicular growth, right before ovulation? Has it gone through that process of getting rid of half of its DNA? Let me show you some images to explain further. This is an egg that's been released from the ovary in an immature state. We know that it's immature because of this structure here, which is called a germinal vesicle, or GV. We can see this with our eyes underneath a microscope, and it tells us that it has not yet lost half its DNA. The egg is still immature. This is a picture of a mature egg, and the sign that we can see here is a structure called the polar body. The polar body represents half of the DNA of the egg, the part that it's dumping out, in anticipation of an incoming sperm. And this is just how it does it. It basically pinches off a portion of itself to get rid of that DNA. Again, normally this process is happening inside the body, and it's a process that's happening in the immediate hours right before the eggs are released, either naturally again or through IVF. So the clinical offering of IVM is to be able to promote that final process of getting rid of half the DNA outside the body. It's much like IVF, except we're just starting with the material a little bit sooner. Instead of starting the lab journey with mature eggs, we're starting with immature eggs. Another way of thinking about that is we're just adding a step pre-IVF onto the process. Now, you might be thinking, okay, well, why would we do this, or why wouldn't we just do this for everybody? To put some context into this, remember, when mature eggs are released from the ovary, by definition, they've already undergone that very important 10 to 12 day phase I described above, where there's a significant amount of development and changes that are happening at the molecular level. If we bypass this, there's a chance the egg will not possess enough of its machinery to make that very long journey to not only first convert to maturity, but then be able to be fertilized and then develop into a high quality embryo that can create a pregnancy. And so clinically, their potential could be impaired or inferior. They just don't have what it takes to make the long journey. That's the answer as to why we don't do IVM for everybody. But to answer the question about who might benefit from IVM, I'm thinking about the following patients. Typically younger individuals that have some inherently strong reproductive potential, that it's so strong that it doesn't matter that you bypass the 10 to 12 days of growth and development inside the body, because the eggs are of such high quality that you can pull them out early and they can still work. The classic example is a young woman with PCOS. Young, because that satisfies our high egg quality requirement, and PCOS because that's a condition associated with higher numbers of eggs, and the higher numbers can combat the diminishment of quality of the immature eggs. A second example might be someone who has physical or mental hurdles in undergoing the ovarian stimulation. Maybe they have some past side effect concerns, or there just could be a frank medical condition that really contraindicates the usage of ovarian stimulation medications. Another example I can think of is someone who just doesn't respond to that typical surge. So we're giving the signal to have maturity happen during treatment, but it's just not happening. Another example would be a patient with newly diagnosed cancer. She wants to do something to preserve her fertility before she goes into potentially toxic cancer therapy. And so IVM offers a very quick way to extract eggs and not delay her treatment for her cancer, but still satisfy the requirement to preserve some fertility by freezing those eggs. So in a nutshell, IVM currently holds a very niche role in all of our treatments, but at the same time, it represents, for some individuals, possibly the only viable pathway forward.